Good afternoon, everyone. I'm Belinda Clarisme, Executive Director of the Harvard Global Health Institute, and it's a pleasure to welcome you today to today's conversation about the evolving landscape of global health intervention. We're honored to spotlight the work of Pivot, a nonprofit organization that since 2014 has been partnering with communities in Madagascar to deliver healthcare that is science-based, community-driven, and deeply rooted in humility and partnership. Today, we'll spotlight Pivot's journey from data that demonstrates the measurable progress to the human stories that bring those numbers to life. And we invite your questions, insights, and experiences to enrich the conversation. Thank you for being here, and thank you to the teams, both in Madagascar and here, whose dedication continues to inspire us. With that, I'll turn it over to Karen, who's gonna guide us through the conversation. Karen.
Good afternoon, everyone, and thank you, Belinda, for your words and your leadership. My name's Karen Finnegan, and I'm thrilled to serve as your MC for our event today on behalf of the Pivot team. It's wonderful to see so many friends, colleagues, partners, and friends gathered here today, whether you're a veteran of global health or new to the field. This event is a chance to not only hear about Pivot's journey in Madagascar over the past decade, but also to reflect collectively on what it means to deliver on the promise of health for all. We're fortunate today to be joined in conversation with leaders and experts who have shaped and continue to shape the field. We'll start with a keynote address, have a reflection, and then a plenary discussion, after which we'll invite conversation and questions with the audience. To start our program, it's my pleasure to introduce our keynote speaker, Dr. Matthew Bonds. Dr. Bonds is the co-founder of Pivot, as well as an associate professor of global health at the Department of Global Health and Social Medicine. His deep commitment to both scientific rigor and community partnership has been central to advancing health equity in Madagascar and beyond. Please join me in welcoming Matt to the podium.
So I'm going to talk about our work in Madagascar. As you know, Madagascar's island nation off the coast of Eastern Africa. And I'll be specifically focused on this area, Fonadine district, which is in the southeastern Madagascar. When we first visited Madagascar, at least when I first visited Madagascar for the first time, as we were exploring possibilities of work that we might end up doing on the healthcare front, we visited lots of health centers, hospitals, and other things. And we came to this health center, which is the Rana Mafana Health Center. It's the health center that is the closest to our headquarters now. And this is actually, was one of the nicest health centers in terms of its physical presence that existed in the district and still exists now. This is, what you're seeing here is better than most health centers in rural Madagascar. And in this health center, when we were there in 2012, there were almost no patients. And in this bed, some of you have heard me say this because it is the origin of where this all work came from. There was a girl who was young, who had cerebral malaria, and was mostly unconscious, half conscious, and had agonal breathing. She was on her path to dying of what is essentially an oxygen depletion. And it was just a coincidence that we were there. We were there with a number of colleagues, including Dr. Michael Rich from here, who at the time was the head of Partners in Health in Rwanda, and he had the sensibility to say, this patient is at risk of dying and she needs care immediately. But there weren't meds in this health center. There were also no meds to treat her in the district hospital, and so we had to procure them privately. And we did, and she lived. And the story that we're going to talk about today is basically the story of why is this happening? Why aren't basic treatable illnesses being treated? Why were they not being treated in 2012? And how can that change? And what can we do about it? That's essentially the story. So as a quick outline, I'll give a little background on the history of how many people in the world think about this problem. I'll talk about the pivot model. I'll share some trends around mortality rates in the country and in the Fonadine district, some more program evaluation and implications for the future. It's kind of a hybrid talk between a scientific talk with data results and sort of the larger story. And then after that, we'll talk about where we are now in the global health movement with regards to places like Madagascar. So there's lots of collaborators. The Pivot has about 300 staff currently. They are all, in every meaningful way, collaborators of the research in terms of literally providing the care and collecting the data. We also have a very big research team. This isn't all of the research collaborators, but it's a lot of them. Mostly Malagasy, some out of Harvard Medical School and elsewhere. If you go back a decade from when we were visiting Madagascar in 2012, the story was, and I'm sure many of you, maybe all of you, most of you remember this, it was extremely hopeful, right? The turn of the millennium, health was being recognized as a pillar of economic development. We had, the most countries in the world had agreed on actual international development goals where health had specific targets around mortality and other programs. There were huge institutions that were created like the Global Fund, Gavi, and many others around marshaling global resources, addressing targeted interventions, and transitioning, both bolstering the vertical, what we call vertical programs, so HIV treatment, vaccines, other things, but towards horizontal, so broader health systems approaches, because the goals went from addressing specific diseases to broader population health. And this agenda, these targets around population health, and this agenda, it seemed commonsensical. So there are many studies. Physicians who don't know these studies, but who treat patients understand that when you treat a patient with malaria, 99% of the time, those treatments work. Many RCTs, many of them unfortunately in Asia, but also some in Africa, were showing that almost all of the common illnesses, causes of morbidity, causes of mortality of children and pregnant women were easily preventable, easily treatable with known solutions. And when people modeled this, when scholars would model this, they said if we implement these programs, if we just reach the goals around coverage, around service coverage, we can reduce mortality by 90%. Those were the kinds of predictions that were coming out of the beginnings of the Millennium Development Era. As data came in and these models got more sophisticated, this is from the Live Save tool list. This is from 10 years later, but the same predictions. This is preventable and treatable illness, rolled out the prevention and the treatment that we know many lives are going to be saved. So this is the story, right? We knew what to do, we just had to do it. Right? That's it. We know what to do. We just gotta do it. Right, Joya? So it's important to emphasize that there are a lot of success stories, among the most notable around HIV care, but there's a lot of others. So there are globally, we've seen major impacts on mortality rates, HIV, death from HIV, incidence of HIV, and including childhood illnesses illnesses that affect children like malaria, for all kinds of reasons. There were many attempts to specifically nail down what happens when these programs that we find in isolated studies are implemented, how they can be integrated and achieve the population development targets for health. So among them, these are among the prominent ones. There are others. The Millennium Villages Project specifically designed to achieve these Millennium Development Goals. Partners in Health and the Doris Duke Charitable Foundation, the African Health Initiative, had specific goals. In fact, the Doris Duke Charitable Foundation funded a number of other projects around the continent. And then other smaller organizations, MUSO, Last Mile Health, Integrate Health, Pivot. Actually, all of us do the same thing in the sense that we integrate programs addressing, among other things, maternal and child health care, and collect actually comparable data around outcomes that are largely aligned with the Sustainable Development Goals, which national governments have targeted. These are just some of the countries where these have worked. But the results have been tricky. So famously, many of you might be familiar with, the Millennium Villages Project did their first 5-year impact evaluation. They they had concluded that the impacts on their intervention area were substantial. There were around 25% decrease in under 5 mortality. In comparison areas, mortalities rose. They concluded that there were 31% reductions in under 5 mortality in just a few years. They were really excited. The Lancet had a big panel around it. It was widely acknowledged as a big success. And then some people came out and said, well, actually, we don't think these numbers are right. You're doing something funny with the rate of mortality that you're estimating on the time period that you're claiming this. And also, as it turns out, what you're finding in these intervention areas are actually not even as good as what was happening nationally in those countries. This sort of like traumatized the community for a while. It made people very concerned around publishing results on under 5 mortality, and it reminded us all how easy it is to make mistakes and how embarrassing it is to make mistakes. They did a semi-retraction. Similar studies like that, UNICEF funded an accelerated child survival and development program. The team from Hopkins, also associated with the LIST tool, later on did a study. This is a similar kind of program, local, district-wide interventions on maternal and child health in 3 different district-wide interventions, 3 different countries, Mali, Ghana, and Benin, and they found that the intervention area had less impact on mortality, lower trends in mortality rates had decreased in their intervention areas less than what was happening in comparison areas. So their conclusion was not that interventions cause mortality, but it's in fact, they weren't statistically significantly different, and in fact, the programs were never really implemented as designed. So this is sort of the bane, these things are the bane of the existence of people like us who believe that health care can change population health outcomes. But that's not it. There are many others. Partners in Health, many of us in the room here worked with Partners in Health in Rwanda. We had seen really, these are under 5 mortality results from Rinkwavu, Southern Kayenza and Karehe district-wide intervention like what we do in Madagascar now. And there they found really high under 5 mortality rates in the initial, at the baseline that reduced and converged to the national trends. And if you look at that superficially, not just superficially, if you look at it honestly, you see this is a really good thing, right? It is a really good thing. You can't ask for better data than that. The problem with the data are, if you look at that baseline, there's wide confidence intervals, a sample size there wasn't really a true baseline. Partners in Health collected the data, the initial collection of their data happened years later. They looked back on other data that had been collected by the demographic and health surveys that were collected anyways. So they had small sample size at baseline, larger sample size in the follow-up. And there's some other issues around their coverage. And there's actually not been a follow-up study on this published. So and I should also say this was published in 2018. I know I'm one of the authors who probably delayed it being published until 2018. And one of the reasons I was delayed is trauma from the Millennium Village Project study, I would argue. Seriously. So it's like, this is good, but published in 2018 for work that started in 2005. Not going to get you a career in global health. Our friends at Integrate Health in Togo, very similar kinds of models, community-based, community health workers and community-based health system strengthening at the health center level. They have lots of evidence of good programs. What they're showing is their under 5 mortality, if you compare it to their intervention area with the rest of the country, also not different in trends. And then this is just another example. There are others, but these are really good, solid examples from our peer organization that do exactly similar work. This is from Muso, working in Mali. They have an outlier on the other side. They're working in Bamako, a very urban area, and they showed under 5 mortality drop by like 85% in the first year or 2. And that's not possible with the way that we measure under 5 mortality rates in terms of, we take a 5-year birth history. So it would take 5 years to fully see the impact of a change in mortality rates. So it must be the case that something else is also going on. Not that they're having a negative effect, you'd rather see that than nothing, but it's also one of these interventions that leaves questions. And as you can see in all 3 of them, there were in none of these cases there's a comparison group. all of them you're comparing to national trends. And so you're left with this question of like, why is it hard to just produce information on something as fundamental as mortality for as a result of healthcare interventions? So I would say this leaves us with a paradox. I'm claiming that it's the biggest paradox in global health. That's how I see it. And it's, there's overwhelming evidence, as we'd seen from the models, that we'd seen that were presented at the launch of this era, that from individual studies that maternal and child health interventions reduce mortality. That's obvious, it's common sense. And yet, almost all of the efforts that have, at least in Africa, where the vast majority, where the highest rates of under 5 mortality exist, and where the greatest burden of child illness is in the world, there's a lack of evidence that integrating maternal health programs in real programs that are rolling out these services produce measurable results in mortality rates. That's the paradox. And I can assure you that if you take this issue to any of our colleagues doing this kind of work, everyone will say measuring mortality is like the thorn in their side, right? It's the thing that's like, it distracts. It's like what donors respond to. It's what governments require. And it's a really hard thing to do. Well, so what's the issue? There's 3 leading kinds of explanations. The first is just, well, maybe programs aren't being implemented as they say they're being implemented. This clearly happens all the time. This is exactly what the Bryce et al. Team said about the UNICEF-funded programs. They said, we don't think these programs have been implemented. That's a thing for sure, or at least not implemented the way they say they're being implemented. So you don't get a signal. There's another argument which is not actually so different than what many people, partners in health, would say, which is medicine's important, but there are other upstream factors, poverty, disease, environmental drivers, that are still there. Even if you treat one illness, they might die. Children might die from something else. So maybe medicine has its own limitations. The other is limitations of the science. So in general, what you'll see from these examples is all of them have fundamental challenges in the data they're collecting. Less an issue of data integrity, although sometimes they're accused of that. More that maybe missing counterfactuals, no comparison groups, no good baselines, small sample size, short time series, a 5-year or 10 years, not a very long time for understanding something as fundamental as mortality rates at the under 5 level, or low data quality. So it's important here, this is the fundamental shift between the kind of science that we do with implementing organizations or implementing initiatives where the programs are built as full-time part of the lasting system, and those with the individual studies that inform those predictions, which is that there's no gold standard. You can't randomize a health system, an evolving health system intervention. We can't do 50 health system interventions over here and 50 over here for a lot of reasons that we can talk about later. So it's a challenge. So I want to talk about the pivot model and how we're addressing this challenge. And I should probably say, if I don't say it enough, that the health intervention that Pivot does isn't, I don't think there's anything specifically unique about what we're doing. We're implementing programs that are part of WHO guidelines. They're recommended by the national policy of Madagascar. They're what our peer organizations do. There's a lot of questions on how to do them and a lot of challenges on how to do them. But the core concepts and how to are not novel by any stretch. So we want to go from here. So we're going from. We want to go from. I'll put it this way. We want to go from this to this. Okay. And what I mean by that is, we want to have a model in every meaningful sense of the word. A model in the sense that it generates a blueprint for how to do the work, how to implement the policies that the national government of Madagascar wants to implement, but also a model system in the sense that we use in science, which is to get a deeper understanding of how this system actually functions. And so we use that. The unit here is a district. That's a good unit for health systems. In our case, and this is true for many, many, many countries around the world, most countries in the developing world, health systems organized the district, the government district is an incredible important unit. There are community health workers who work at the village level, in our case, Fulcantani level, which is a cluster of villages. There are health centers that operate at another level of organization, and then there's a district hospital, one district hospital per district. That's a very standard thing across the world. We work with the Ministry of Health at all these levels of the health system. And we implement the kinds of health system strengthening programs that we learned from our colleagues at Partners in Health: staffing, staff, resources, supply chain infrastructure, systems of care, physical space. Specifically, Pivot has community health worker programs, facility-based health system strengthening, which includes removing user fees, infrastructure upgrades, training, staffing and training personnel. There's multiple kinds of data systems. Some of the data systems, in this case, we're talking about that are in the health system itself, the monitoring evaluation systems for the government, the health information management systems. Then there's maternal and reproductive health programs, so maternal waiting homes, birth kits for newborns, and referral systems. These are sort of the subset of kind of core interventions, but there's many more. There's emergency care, there's infectious disease, there's emergency responses to other things, but these are core programs related to maternal and child health. So in addition to these, some people call them the 4 S's, there's a 5th in this case, and it's science. So we have a few unique sources of data. One are household surveys. The other are, I mentioned this before, the Health Management Information Systems, HMIS. These are registries, patient-level data. And then there's the kind of data that come out of the environment or geolocated through geographic information systems. So I'm going to walk us through these kinds of data and show how they help us get a sense of what's going on in terms of the impact of the programs on population health. So the key features of our household survey are a few important, unique aspects of them. So one is it's district representative. We have a representative survey of households in an initial catchment area, the first area where we intervened. And then data from outside the initial catchment area. It's longitudinal, so we follow the same households over time. So it's really important because if there's widespread demographic change, and you might see outcomes that aren't related to the services that you're providing those particular households. It's standardized. We don't collect these data. They're collected by the National Institute of Statistics, and they analyze them, and then we reanalyze them, so we have redundancy in the analysis. Mentioned that. And it's long-term. So we're following these households. Hopefully, it'll last as long as the interventions themselves. So we're getting what is now over a decade of data from people from actually starting before they were born, same individuals past that. So these population-based household survey data are how we measure. That's our basis for mortality. I'll follow up on the other sources of data first. And I'm going to just walk us through what the mortality data look like, and we'll see how. I want you to have an honest response. Look at the data. Don't listen to me, and tell me what you're thinking. Okay? I'll tell you what I'm thinking when I see that data. I think that's not very exciting to me, right? That's the one. What you see is Madagascar, and you see Madagascar's under 5 mortality is. They collect the data less often. We collect it every 2 years. They do every 5 years. So you'll see less. The under 5 mortality is the one below the gray, and over time it's been rising. That's not great. Ours looks like it's been falling, but I don't know. It's a lot higher than the national trends. This is infant mortality, neonatal mortality, all kind of a common story. So if you look at that, and you were to publish this, if we just said, okay, this is our impact, it's sad, it's part of the same sad story of every organization, every project, organization, effort to change population health impacts. We would be forgiven for just having the same results that everyone else suffers from. But if you look at the data more closely, there are stories that come out of it. So this is just the differences of that. So if you just subtract the data point from its original start, so everything starts at 0, and you just look at how it changed over time, that's just what you'll see there is that it's not super encouraging either, but gives you another way of looking at it. You see, okay, the under 5 mortality looks like maybe it's dropping compared to the national trends. The others are rising. Not a whole lot more encouraging, maybe slightly more insightful in some ways. But that was for the whole district. Now, what I didn't say very clearly is that what makes this different than a typical sort of a classic randomized trial study design is that we're operating under real-world systems that are just evolving and growing over time. So really what's happening is we have an initial catchment area of part of the district, and then we have the rest of the district that eventually we eventually roll out as the systems improve, the staffing. We have protocols and staffing and organization and all the normal delays that are necessary when you roll out big health systems change. And so here, I'm going to jump to these bottom things because it comes out a lot quicker. You see two big things. So the orange is, I should say the green is the initial intervention area. So these are a population of a subset of the entire district. This population is about 60,000 people. It's an intervention. First 60,000, one group around 60,000 folks. The rest of the district is in orange. And there's an orange dotted line there, which is 2021, which is when the programs that were started in the initial area, again, these are like the removal of user fees, the community health programs, the infrastructure upgrades, staffing to norms, how they were starting to adequately be scaled to the rest of the district. So what you see there is a much different story, right? You see in the initial intervention area where we had pretty high quality data, under 5 mortality rate was actually dropping pretty significantly. It's dropped about 30%. The rest of the district was not dropping until there was some exposure to the rest of the intervention area, and so that started dropping too. A similar story to infant and neonatal mortality. Infant mortality is dropping, neonatal mortality is dropping, and in the rest of the district it was not dropping. This is like not squeaky clean for all kinds of real-world reasons, but what you're seeing is a clear divergence from the intervention program to the rest of, to the comparison area over time. So this is data that we can only do because of the granularity and the high number of data that we had for part of the district, which is not normally how people are able to collect the data. So now I want to talk a little bit about, okay, maybe that's something, that's not bad. Do we have evidence that the programs are actually being implemented, right? We said that there are some arguments that programs aren't happening. And for that, there's a lot of evidence, right? So I just showed you household level data. Now I want to show you data from patient records. So this is like a very high level graph. So these are total consultations that Pivot has directly supported. It's about almost 2 million consultations now. It's gone from a little less than 30,000 patients a year at the beginning to almost 300,000 patients a year now in the district. A way of breaking that down further, this is patient utilization rates. So the green is the intervention area, same story as before. The orange is the rest of the district. The green you can see this is per capita utilization, the probability, the number of times the average person or child or mom interfaces with the health system per year. So it's almost hard for me to read. So the first is the outpatient for consultations for all ages, the upper left. The upper middle is the under 5 outpatient. Then you've got prenatal 1, prenatal 4, so 1 PNC visit, 4 PNC visits, delivery, and then postnatal care. And what you'll see here is, of course, is that major services, or at least major provision of services happening over the intervention period. And then, of course, thankfully, and as it gets scaled in 2021, 2022, 2023, it converges. It's a very convincing story. That's probably, for the most people in the room, that's probably enough that you believe the services are being provided. For academics at a lot of places, that's not enough. You have to prove it. You have to show another analysis. So we'd use statistical models to evaluate the specific impact of the programs, a specific impact of the community health programs on utilization, the specific impact of the facility-based health system strengthening, and controlling for other things. So I'll walk you through this hopefully not too quickly or too slowly, but quickly enough. One thing to notice about this is that at baseline, the consultation rates were about the same in the initial area and the rest of the district. That's what this is saying. The facility, I should say, you should be clear about the analysis. This is a statistical model from monthly outpatient data registries at health centers. This includes data that might be influenced by the community health program to the extent that that influences outpatient consultations at the health center, but we're talking about health centers here. So the facility-based health system interventions, mostly user fees, infrastructure staffing. What you can see is after controlling for everything else, a doubling in outpatient visits for all ages, something like a doubling for children under 5, and increase of prenatal and postnatal care. Something subtler here is happening where when this program-specific HSS refers mostly to community health programs. What that's saying is that when we started rolling out community health programs, some patients were coming to facilities less often. If you look at the combination of these two, these are basically the body of interventions. You're seeing roughly a doubling, a 1.5 to 2 times increase in total services. I'll show you the community. This is not community health data. I'll show you that in a second. So back to this population-based data again. So I just showed you data that comes from registries. So there's a lot of data from registries, high volume of data from inside the intervention areas and outside, and changes over time. We're back at population level. And what we want to do is we want to see does this independent source of information correspond to the data we're collecting? And sure enough, like this is from household surveys, you can see the left and right of each is the beginning of the baseline time and the most recent follow-up time of 2023, and increases in all of these services. And I'll show you some more data in a second. So importantly here, our models show also no significant differences in baseline of how people respond and they answer these survey questions on their health-seeking behavior. So when they got sick, did they get care? When they were pregnant, did they do their PNC? Did they deliver in a health facility, et cetera? So not significant baseline differences. And then the facility-based and program-specific support, you'll see this is a little trickier. Your sample sizes are a lot lower. We're talking about household surveys. In some cases, sample size might be 100 or 80 children, depending on the exact circumstances. But you'll generally see, even then, you're seeing a positive signal on all of these, right? A positive signal and then statistical significance, at least one of them. On the program-specific, this is the community health worker support or the facility-based interventions. So you're seeing a signal that households, when these programs are being implemented, they report that they're using health systems more, and then we check the registry data, and people are using it more. So that's the basic story. I'm going to go through one more set of data, and then just to provide a slightly richer impression. And then we'll start wrapping things up to the larger story. If you looked at the data from before and you noticed that the mortality rates are kind of going up and down at their early stages, and when we saw that in 2017, we were concerned. We didn't know if the issue with this is a lagged effect from the data or what. We have information that people are using the health facility, but who's using the health facility, right? Patient data is not representative of the population. So we did this enormous geographic study that's continued to develop. One of our key figures on this is the Felana Ihanta Malala, health geographer of Malagasy, one of the leaders of that. Another, Andres Garcia-Tredena. And what Felana did is she mapped every footpath in the district, about 20,000 kilometers of footpaths, 100,000 individual facilities, every structure, house, building, school, et cetera. And then she and the team estimated the exact travel distance from between any 2 points in the district using some software. It's called open source routing machine, and estimated the travel time and distance from people's villages to the health center. So we took all the patient records, a few 100,000 patient records at the time, identified where people were coming from, how far they had to travel, and then we were able to produce something like this. So this is, the x-axis here is the distance from the health center, from their village to the health center from this patient record. The y-axis here is the average consultations, which I've been using as a metric. And what you can see is this This distance decay says that folks who live close to the health center use the health center a lot. Folks who live far from the health center, this is the black line, use the health center much less often. The gray line is the community health program. So folks who live further from the health center are actually more likely to use the community health worker program. And so, in fact, it pretty much totally offsets that. So if you look at this in another way, I don't have it presented here, you have almost no distance decay in primary care services in terms of total consultations. And if you don't believe that, we looked at it another way, which is just asking people. Depending on, we know where people live, we know how far they're away from the health center, your child was sick, did they get care? And in 2014, this orange line, it looks a lot like what we expect, right? As it's the numbers are different because people are self-reporting from surveys, and it's different than like measuring things from geographic information systems. From the registries. But you see the clear distance decay. That's the classic story. But in 2023, that was basically vanished. So no matter how far away in a founding district, no matter where you're living in the district, your child under 5 is as likely to get care as anyone living close to your health center. So there's a lot of things that we do with data, but these are the biggest, highest level summary stories. And the power of this is the uniqueness in the totality. So I just want to review it really fast, what we just saw. So what we saw is we have health information systems data, which is from patients. It has high sample size. It's continuously collected inside and outside the intervention areas. There's variability of the programs over time and over space in the district. Household surveys are giving you data not necessarily from patients, people just who are living in the population. It's representative from an intervention area and a comparison area. Those spaces change over time. It's independently collected, not us. It's longitudinal. And in this case, it allows for multiple counterfactuals because we can compare the intervention area with a comparison area in the district, and we can compare it with national trends. And as it turns out, in our case, where those ended up being the same story. The comparison groups and the rest of the country were along the same path. The intervention areas where we were on a different path. And finally, the geographic information systems allows us to connect the data between the patients and the population. So we have patient records. There's something between, like something happens outside of the patient's story that gets them to there and allows us to analyze who that is. So finally, and what we conclude is, what we found is what I just said, decreasing trends in under 5 infant neonatal. I didn't show maternal mortality results because they're not in this paper, but I'll mention, maternal mortality actually was also dropped by 50%, although we don't, because of the nature of the sample size, we don't have a comparison group. So all we have is a 50% reduction, district-wide maternal mortality. Huge accomplishment in its own right. Increases in system utilization and service coverage, decreases in geographic and economic inequalities and access to care. And then, what's it cost? Karen and I were joking. We said, if so-and-so saw this, they would say, that's really expensive, right? But if you're a human being, you would say $60 total is a really small amount of money for major reductions in mortality. So to give you a comparison here, and the important thing to note here is, just like everything I just showed you, there's no gold standard for estimating the costs. Costing is a funny thing. It tends to be done at national levels. And there's not like a standard for like, okay, how much money is being spent in this district? And so Karen and team did the hard work of like finding up all the resources that were coming in, that were showing up at the facilities, from partners, from the government, from Pivot. And we estimated that that the government spending was landing in the health in the district in the system was about $18 per capita. Pivot was roughly doubling that. Our contribution was double that, but not double the whole thing because there were other partners. So in total, we're seeing about $60 per capita investment in the health system, which includes like the ambulances and et cetera. So just really quickly, and then we'll get to the panel. That is at the district level. The government has asked us to expand the model. We are now in the process of expanding from 1 district to 3 districts. say now, if you've been paying attention, you would say, well, Matt, you said now a year ago. It turns out that it takes at least a year to expand from 1 district to 3 districts, so we're still in the process. It started like a year ago. So that's a population of 200,000 to 1 million, work from 21 health centers to 87 health centers, 1 hospital to 3, and then roughly 200 community health posts to 700. And we're in the middle of that. We're in Vatavadavi region, in Nosy Varika, the whole region's Vatavadavi. So Nosy Varika, we started working in. We recruited some 1,500 community health workers jointly with the ministry. And the work and the evidence that we produced around the community health program ultimately informed the new national guidelines on community health, which adopted almost all of the policies that we ended up recommending. So, and they made us become their partner to expanding that. So that's where we are. Process of expansion, totally new context. And I have one more slide. So we're going to the coast, as you can see. So now our ambulances are on boats and things like that. So one other shout out, expanding the program creates a lot of opportunity for refining the model, right? So how do you partner with the government so the work can be done at a larger scale? But it also changes the science. So there's a rule in science that more data is better. And in this case, going from a household survey of 7,000 individuals to a household survey of 24,000 individuals is a huge deal. When that's what these little clusters are, these are data have been collected. The baseline has been complete. And I'm doing this as a shout out. I'm not getting into it. We publish a lot of papers, but there's a lot of stuff that happens when you start asking, when you collect a lot of data, you ask, when we're looking into what are the causes of illness, what are the incidences of various kinds of illnesses? How can we anticipate that in the future, and et cetera? So we're doing a lot of analysis around the infectious disease space and other things, and looking at how the model will scale at a higher level. So I hate doing acknowledgements because it's like such a small function. It's like a very small subset of the folks involved in this, but clear funders of research. Yes, there has been federal funding in the past, but most of the research is funded by private foundations and individuals. And in fact, we've had some resources we've had a number of not trivial grants from Harvard Medical School, and actually Pivot itself funds research, so we've included that in the acknowledgements. I don't know if I said it, but this paper's been accepted in PLOS Medicine. It'll be published in the next 3 to 4 weeks, something like that. And that's the real research team. That's the crew, people who do the work. So thank you, Ms. Sartre.
Thank you so much, Matt, for those remarkable insights and reminding us about the challenges and the opportunities of this work. To deepen our conversation, I'm honored to introduce Dr. Carol Mitnick. Dr. Mitnick is a professor of global health and social medicine at Harvard Medical School, senior research associate at Partners in Health, and an associate epidemiologist at Brigham and Women's Hospital. She has worked for over 25 years in expanding access to effective treatment for tuberculosis worldwide, and she spent her career advancing health equity through research, policy, advocacy, and activism. I'm honored to call her a colleague. Please join me in welcoming Dr. Carol Mitnick.
Thanks so much, Karen, and thanks for the opportunity to respond to this really extraordinary scope of work. When Matt asked me to respond, he said it was because he considers me one of the first wave of researchers at Partners in Health and also one of the first wave of Pivot supporters. I think he really asked me because I grapple with how to do research in service of equity with a deep understanding of the intentional structures that are designed to actually undermine that equity. But what he didn't know is that I've been grappling with these questions for a really long time, starting with actually my ambivalence about even completing my doctoral degree, when what I genuinely wanted to do was be an implementer. And it was a little bit hard to reconcile a research path early on. particularly because some of those early research experiences or exposures were much more about how not to do research. So you also don't know, Matt, that the very first grant proposal that I worked on when I was a doctoral student, which thankfully we did not submit, was with my then brother-in-law, who was a physical anthropologist, and it was basically doing anthropometry on children in Madagascar. And to me, it was really reducing centuries. I didn't know this at the time. I know this now, why it bothered me. It was reducing centuries of slavery, of exploitation, of extraction, of all of these other factors to these few measurements, to measurements of weight and height and arm circumference. And I just knew I was uncomfortable with it, but I didn't really know why. And it's been these years of collaboration with PIH and other like-minded organizations and people like Joya who really helped me to apply that lens. And so my grappling has really been around where in this long chain of traumas that affect the individual lived experiences of people do we intervene? And we, from conscious that we are coming from the global north, that we are coming from those populations that have traditionally been the exploiters and the extractors. So where do we intervene? Where do we disrupt in these patterns that have been created over centuries? And how do we disrupt within a global health framework that expects simple and quick solutions, that sets these arbitrary timelines of 5 years or less, that uses arbitrary thresholds on the amount of money available that have nothing to do with the inequity in the way resources have been allocated over history and in the present time, that expects direct and very narrow matches between interventions and the indicators used. So Karen mentioned that I do TB research. It's very common to expect if you're doing an intervention on TB treatment that the question you're trying to answer is how many more people were cured by that TB treatment. If you're doing an intervention on, say, PrEP or preventive treatment for HIV, you try to count how many cases of HIV were averted, how many infections were averted. Super valuable in things to measure, and I'm all in favor of measuring them, but it's only part of the picture, right? Because if I just look at those cures of tuberculosis, I totally lose sight of the chronic conditions that have been caused by that TB, and also possibly by other environmental occupational risks that are, again, secondary to this extraction, but that may result in premature death, even though we've managed to successfully cure more people with TB. And analogously, for women who might avoid an HIV infection thanks to a PrEP intervention, that doesn't protect them from being marginalized, from being victims of rape, from being ostracized by their communities. So these are the problems and pitfalls are really daunting for those who grapple. And that's what makes the work of Pivot, the work done by the two Lucs here and several others in the room, as well as hundreds around the world, that's what makes it so remarkable, that the result of their grappling with a legacy of complex structures of oppression is a complex redress. It's a complete overhaul of a health system which had been cobbled together in the wake of this unjust history that we've been talking about. These folks have worked for over a decade to influence a single set of foundational indicators, so child mortality, that is under 5, neonatal and infant mortality. And their whole health system strengthening package acknowledges a long and frankly embarrassing history of failure, which Matt described for us, of global health professionals, in part to integrate enough health and systemic interventions to really move these stubborn and telling indicators of how the world devalues the lives of children in low-income settings. So the health system strengthening applied by Pivot that we saw the results of today is comprehensive. And I'm going to highlight a few things that Matt did say, but things that to me are really, really important for addressing this complexity. It systematically removes barriers that caregivers face whenever and wherever they seek care for their children. It brings the care to the communities in the form of community health workers and additional community health posts. It ensures that those community health workers have the support that they need to be confident in delivering care. They're not left there by themselves. They have professional supervision and support, and they get paid. And Pivot ensures the availability of medications for these communities, but without requiring community health workers to pay out of pocket to increase this, to make the supply available, or without incentivizing community health workers to turn a profit on those medications, which were the systems that I understood kind of predated Pivot and that exist in other parts of the district. And then Pivot also offers parallel interventions at the community level, at the health center level, and at the hospital level. So with eliminating the costs, both direct and indirect costs for people, or reducing the direct and indirect costs for people to access care, raising the quality of care, reinforcing that, and including much better medical information. We saw that the consequences of the medical information system to afford a continuity of care. And Pivot documents scrupulously, fully, and unapologetically. And again, that's why we could see all of these different sources of data used to triangulate and generate this information presented today. As Matt noted, the individual interventions comprising the whole health system strengthening approach, they're not rocket science. They're known to many of us, to many implementers in the global health space. But what was really unique was the assembly of all of these interventions and the fidelity to the intended model. And it by doing that, it creates this complete coverage and closes gaps through which young children often fall or literally are pushed by the system and would otherwise die. And one of the other things that was remarkable to me about it is it does it without falling into many of the traps that we have fallen into in global health. So it doesn't pit the community services that people might need on a daily basis against those hospital services that are needed less frequently. It doesn't pit preventive care against curative care. It doesn't succumb to the myths that poor people have to pay for services in order to value them, or that community health workers should volunteer to serve their neighbors. And it does this without imposing an artificial 5-year timeline on something that's just incredibly complex and stubborn. The continuity of this health system strengthening program inherently acknowledges that centuries of mistreatment and underinvestment take a long time to redress, and that it took 7 years from the start of the intervention in the initial catchment area to achieve these remarkable population-level reductions in infant and neonatal mortality is a testament to the stubbornness of the extant conditions and the importance of a commitment to stay and to persist. Now, remarkably, these declines occurred in the initial health system strengthening catchment area while the surrounding population was actually experiencing a tragic increase in the loss of young children and countrywide declines of other indicators. So the contrast between the outcomes in the Pivot-supported area and the surrounding areas, for me, really reinforces the value of a sustained intervention. Now, Matt kind of alluded to this. Skeptics among us, and probably among the reviewers of the aforementioned PLOS Medicine manuscript, might say, well, wait a minute, let's not get too excited. This was not a randomized controlled trial. How can we be sure that the observed changes aren't due to baseline differences in the populations or some other external factor that affected the areas differentially? So let's talk about design alternatives that might have been considered. The authors used this quasi-experimental longitudinal district representative cohort study. That is a mouthful. And it could be argued that some formal cluster randomized, stepped wedged, or crossover design would have achieved greater certainty about the impact of the intervention. And to that imagined criticism, there are moral and technical responses. Matt has really well covered the technical responses, although I'm gonna pick a slight bone with you on one of them. But I want to address the moral response, really. And this brings me back to the grappling in a more practical, less abstract level than the way I introduced it. So also, since my early days in public health and training and research, I've grappled very simply with how to move resources to introduce common sense interventions to the areas most in need, how to provide those services, which we know work in other settings, and continue to justify that they work in these new settings because that's what's necessary for those who hold the purse strings. And how do we ensure that basic rights to food, to clean water, to education, to safety, and to the sharing in the benefits of science are fulfilled whether or not we have evidence of their cost or other forms of effectiveness, right? If these are rights, the effectiveness shouldn't be an issue. So in my own experience with PIH, we rose to these challenges by doing observational studies of treatment of drug-resistant TB. That's what I know. I'm a one-trick pony. I just do TB. And admittedly, these studies were way less rigorous than what Pivot has done here, but I'm not going to get technical at this moment. Our studies simply demonstrated that treatment that was used in the most kind of premier TB reference center in the US could be successfully delivered in low-income settings, that could be successfully delivered in urban shantytowns in Peru, in rural Haiti, in prisons in Siberia. We couldn't endorse a comparison to a so-called local standard of care because that standard was inadequate and it was inhumane and it was not worth investing in. And randomization requires a lot of investment. And I say it was inhumane because the alternatives at the time, the very first scientific conference I attended when I shared the initial work that PIH was doing in Peru to treat MDR-TB, one of the questions from the audience, and this was 1997, and I remember it so vividly, one of the questions from the audience was, well, you know what I think you should do? Because I think it's immoral to spend all this money on the treatment of drug-resistant TB. You should just put those people in a hut on the side of the road, give them some food so that they do not infect their families and neighbors, and they should just die quietly alone. So that was one of the alternatives, obviously not a comparator that any of us would be interested in. And the standard was to just treat people over and over again with what we knew was the wrong regimen. So randomization was out of the question for moral reasons in my mind. And so the alternative, these observational studies demonstrating the feasibility of it, estimating the human and epidemiologic burden of MDR-TB, and yes, exposing the threat that MDR posed to other people. We did stoop that low. And by using moral suasion, ultimately these results contributed to a change in practice, a change in policy, a change in standards around the treatment of MDR-TB. And so I see this as really analogous to what Pivot chose to do, the design, the work, and the design choice. And it was only possible because of the dogged commitment to really rigorous data collection, longitudinal data collection. But they did not fall into the trap of investing in a scheme to randomize people, randomize humans to a comparator that was known to be substandard. They knew that there could be no equipoise in randomizing communities to a health system status quo that literally allowed tens of thousands of its youngest to perish. And I know, Matt, you represented this as a complexity issue, and I'm gonna come to that at the very end because you don't shy away from complexity. But to me, this was a principled decision, at least in part, that you adhered to your principles to generate evidence to inform this work. You didn't have to give up that principle, Robin, of being data-driven, but you deployed a number of elegant techniques, and you talked about those really, really thoroughly in your presentation. And so thinking about the next stages and kind of the parallel that I've gone through. So I have, almost 30 years into my career, I continue to grapple with how best to gather higher certainty of evidence to promote health equity. And after the principle of treating MDR-TB in low-income settings was generally accepted, I did relent and actually begin conducting randomized controlled trials to optimize the treatments. I did them in partnership with PIH and with other care delivery organizations that valued dignified care and that worked on the underlying mechanisms that put people at risk of drug-resistant TB. And I've even gone so far as to argue that in the regulatory framework, when we're talking about like the FDA and the European equivalent, that anything short of randomized controlled trials is probably doing an injustice to people who are sick with TB. That level, a single observational study would never be considered acceptable for conditions that affect large numbers of Americans, and so it shouldn't be considered sufficient for a disease that disproportionately affects the poor. So whether the next phase of health system strengthening in Madagascar and the next two districts is better suited to randomized controlled trials remains an open question for me. The pivot work leans into ecological theory, which demands adaptation in the face of response. But this doesn't preclude randomization, especially for people unafraid of complexity. Adaptation based on response or other population characteristics is increasingly accepted in trials, and methodology to optimize its use is also maturing. And whether the convention that trials tend to be oriented around simple, singular interventions is inherent to trial methodology or an attribute that can also be adapted in pursuit of equity, for me, remains an open question. But with the expansion of strengthened health systems as the goal, I would posit that the question to be studied, whether or not it's submitted to randomization, is how, not whether, to effect this comprehensive change in more places. And I can really think of no group better placed to pursue this than Pivot, no foundation better than the really strong foundation of data and work that you've already done than to pursue this challenge. So those are my thoughts.
Thank you, Carol, for those thoughtful reflections. I know I'll be thinking about these comments for a long time. We'll now turn to our plenary discussion, in which we'll dig deeper into the future of global health, focusing on questions of systems equity and innovation. This session will be moderated by Dr. Joya Mukherjee, Associate Professor at Harvard Medical School and in the Division of Global Health Equity at Brigham and Women's Hospital, and Chief Medical Officer at Partners in Health. Our panelists today offer a wide range of expertise and unique perspectives. Joining us today are Luc Rakotunurina, who joined Pivot in 2014 as a founding member of its clinical team and is now the Deputy Country Director. Luc oversees our strategic partnerships with the Ministry of Public Health and provides vital support to the Pivot programs and clinical teams on the ground. Also joining us is Professor Luc Samuelson. He's a distinguished physician and a health leader in Madagascar. He currently serves as the president of the country coordinating mechanism for the Global Fund grant in Madagascar and as director of the Centre d'Infectologie de Charles Meyer at the University of Antananarivo. He's formerly the dean of the Faculty of Medicine at the university and currently serves on Pivot's board. We'll also welcome back Dr. Matthew Bonds and Dr. Carol Mitnick, who'll stay with us to share their perspectives and continue this important discussion. There will be time at the end for questions from the audience. So please join me in welcoming Joya and our panelists.
Thank you so much, Karen and Matt and Carol. That was extraordinary. It's an honor for me to have been asked by the team to moderate this panel. I think I have the photographic negative of Carol because I really wanted to be a scientist, but I couldn't do science. They kicked me out of the lab. But what I can tell you just briefly is that when we first started doing HIV work in Haiti, and we're writing the first article on the patients that were getting therapy, I did a PubMed search on global and HIV, and there was only one scientific article that I could find that had been published, which was about the global lengthening of eyelashes in people that were on antiretroviral therapy. And I was so outraged that someone would write an article on something so stupid. And I think part of the game in publishing and in academia can just be getting those papers out without meaning. And without the idea of righteousness that Carol and I were talking about. And so I just want to highlight, where in this long chain of trauma do we intervene? Thank you, Carol, for that. That will stick with me. And where, and how do we approach data with a question that will really be impactful in the lives of people? And so I think, as a booster of Pivot and the work, when we start with questions of efficacy and of how to get these interventions, Pivot has been really without peer in that. And, I'm just grateful for the work that you've done, Pivot and Matt, and of course, Carol, for all your leadership at PIH with Michael and others in really changing the paradigm. So what is the role of how we integrate these things? So this conversation really matters to us because data can be wonky and sometimes boring, although not when Carol or Matt talk about it. And yet we are uniquely positioned at Pivot to combine the lived experience with providers like Luke, with country level leaders like Dr. Samuelson, with this data. And that allows us to show that we can have measurable change. There are still people, and in fact, right now we have a blip increasing people who think this work doesn't matter, that we shouldn't make these investments, that these are not our people, ergo we have no stake in this. And so understanding that something important has happened in Madagascar and that it's happening at scale. We also want to understand that this is just the beginning. 10 years is an amazing milestone. It's half a generation demographically, and yet we need to do more and for longer because these traumas that Carol mentioned are intergenerational. They're long-term. The solutions cannot be parsed out in 2-year intervals. A lot of development has been a 2-year project, a 5-year project, a 1-year project with an exit strategy. We don't exit from communities that we are committed to. These are, our families and our people. And I hope that this science gives us all optimism, that we can do something, we can show that we did it, and we can use that data to really change the paradigm. But at the end of the day, it all starts with one individual patient. Luke told a beautiful story last night about one individual patient, and we're just so grateful for that. So I wanted to start with you, Luke. How has evidence influenced the way you deliver care, but also how did the stories influence the evidence that you want to collect?
Thank you, Joya, for this great question. Maybe I will answer this question by sharing you or presenting you the general structure between science and PIVO in general, or the program in general. So within Pivot, there is what we call Pivot Science. So Pivot Science science is part of Pivot that leads and oversees the research program within our organization. And in our side, there is PivotWorks, which is us at the field implementing and developing project in Ifana district. And within PivotWorks, we have like a sub-department about a monitoring evaluation. We have a lot of staff who leads these activities, and monitoring evaluation support private science and PivotWorks and collecting data, analyzing, interpreting data, and also providing essential elements for research specifically. So these three components are interdependent and inseparable for us. So the main purpose of having private science with Pivot is to generate evidence first. So this evidence are used for us as programmatic to in shaping like the strategies, like the guide, how should we conduct the project at the field in order to reach our goal. So there is a lot of research or study that the research team have made since then. But the things that we do daily, like we have a regular meeting between research team and programmatic team in order to define like some objective of research. For example, okay, when we, if we can come back on 11 years before, we started developing the project by doing like a baseline survey. So after that, it shows that the real problem in Ifana district was like the social financial barrier. So for us, it's important knowing that to develop what kind of project should we implement or develop. So at that time, we prioritized like the health coverage program. We removed fees for the population in Ifana district, for example. And then, after 4 years, we would like to know as a programmatic team, does this project respond of the needs of the community, of population, for example? The research team does like a study around this in order to know if the population has access to care, for example. And at that time, we know that just the people around 5 kilometers at the health center which benefiting healthcare, and then the rest benefit less. You know, so this information help us to readapt our activities, and then with the ministry we decided, okay, we should strengthen, for example, community health program. At that time we implement the community health program, recruiting more CHWs, training them, motivating them, and supervising them, for example. So those evidence is important for us as program to adapt. I mean the program, even the event today, they do this study for the 10 years. Is there some impact for those 10 years as an effort? And we know that, yeah, there is. So for us as a programmatic, we will expand these activities to district, why not for the whole country? So those are important to defend that science is important. Science is needed for us as a programmatic department. Thank you.
Thank you so much. That's an amazing answer, and I have to say it should be a guide to all of us who are in the education space and in the academy, that the best questions actually come from the field. And you're also demonstrating a kind of the humility to be a learning organization, because sometimes we do an intervention, we say, oh, this is great. Yeah, it's great to have free care. But it's humble to say, is it great enough? And who is it not helping? And I think that's a beautiful story of how iterative data and learning is such an important part to improving care. And so I'll go from that idea of education and knowledge and the academy, Professor Luke Samuelson, as a former dean, and as someone who sits in important positions, especially for those of you who don't know, the country coordinating mechanism is a very important body in countries that tries to bring together NGOs, civil society, commerce, with the ministries of health and education to make decisions. And I'd love to hear from you, Professor Samuelson, about how Pivot and how data can help you in doing your job for the government and the people of Madagascar.
Yeah, thank you very much for your question. Yeah, the main thing that we know today is that there are good results from Pivot. These are based from the data they collected on the field. And nowadays, the Ministry of Health in Madagascar prioritizes the use of data. For example, the C19RM, which is the COVID-19 response mechanism, try to strengthen the advantage that we've gotten from the fight against HIV, malaria, and tuberculosis. And in that program, the reinforcement of the data collection is a priority. That's why the C19RM is funding the implementation of the HIS2, which is an open source software platform in which the country can collect all the data for all the diseases on the field. Infectious diseases such as tuberculosis, diarrhea, pneumonia, and also non-communicable diseases. All those information are now collected via this platform, and the Ministry of Health can have a real-time data on what happens in the field. This software, in fact, is used in many African countries right now, but also in Asia, in the Middle East, in Latin America. So this kind of use of data is very important nowadays for the government, and it eases the decision making right now. We knew also that in Madagascar there is the PMM, which is the PMI Measure Malaria. You know the program of PMI, the Presidential Malaria Initiative from the United States. This program funded also the collect of data for on the field for the malaria, and that permits the government to respond quickly to the outbreaks in some areas in Madagascar. There are some regions which are hotspots, if I can say. And perhaps the last example to say that data is really, the data matters for the Ministry of Health is about, for example, the fight against HIV. Lately, specialists in Madagascar found that they found more and more positive cases of HIV. So the government asked financial and technical partners to fund a survey, which is a seroprevalence survey in pregnant women, because it is very expensive if we do it in the national scale. to have the real prevalence in those hotspots. And we are now analyzing the data from this survey, and it is very important then for the national program to fight against HIV to have this kind of data. So the policymakers right now rely completely on the data in Madagascar. Thank you.
Can you run our country coordinating mechanism? No, I mean, I think it's really important to remember that what Madagascar is doing in relying on health data and real-time health data is really impactful. And it showed really during COVID where, in the United States, by the way, none of our American states have the same data collection system. So our data is extremely fragmented. Even within the state of Massachusetts, a more public health oriented state, we have 331 boards of health. So this kind of coordinating of the data is so important, and with people like you at the helm is really a way that the country can move forward. So that's great. I'd love to turn it over back to Matt. Why do you think it was so hard? You were working in Rwanda. You had been part of the Millennium Development Project at Columbia before we stole you, thankfully. But what do you think is so hard? Why are people reluctant to get this data or to really look at it in the rigorous way that you looked at it?
I think you can still hear me.
Yeah.
Why is it so hard? There are two things that are hard. The implementation is hard, and the data collection is hard. And I think if you look back at most of these efforts, they fail on one of those two, actually. So there's some, as a general rule, there are projects that tend to focus on the data. They might suffer on the complex interventions. And you tend to see that, honestly, with a lot of multilateral initiatives, right? There's a bureaucracy around the initiative, and then by the time it gets to the intervention, you see less of a signal, and the fidelity becomes an issue. I think with a lot of these bottom-up efforts, they're focused on the interventions. And so generally, what you're seeing are programs that are, when you're doing these programs, it's like, especially at the start, well, always, but it's especially hard at the start, you're hiring staff, right? You're responding to an actual clinical, medical need. You're figuring out the partnerships with the system. There are many unknowables about the path of growth, right? I'm gonna be interested in this randomization question because it gets to that, right? It's like it's gonna stress me out. That's, by the way, but we'll talk about it. But there's a lot of unknowables on how to do a proper design, right? And so then what one has to allow is like, okay, before we have solved these unknowables, we're going to put some kind of data system in place. And it's going to both allow us to do some prospective study analysis and also allow us to retrospectively analyze. And that just requires some combination of the systems people and the data people. And fortunately, to be honest, you guys stole me from Millennium Village Project, but I stole everyone else in Partners in Health. And so then
a lot of stealing.
Yeah, it's a lot of stealing. Karen's stolen, Michael stolen, and so we had good people on.
I think we still have Michael.
Yeah, I noticed actually. He went someplace, but back. So we learned from that work in Rwanda, right? We were able to implement some of the programs that we've been trying to implement. We had a head start, and then we got lucky on the funding, right? With Jim and Robin Hernstein, who said, "Okay, we don't have a project. There's no website. You're barely incorporated. You don't have a staff. We have no reason to have any faith in you, but we're going to spend money on collecting data anyways, in addition to everything else." And it's hard to get the resources and mobilization at the ground stage. It's just a hard thing to do, right? And so we learned, got lucky, that kind of thing.
Thank you. Carol, I'm wondering if you have so many examples in your work of why we need the data. Because, some of it is like, duh, you treat a kid for malaria and they survive. So what has been your experience on why we need data? Who is that data for?
Yeah, that's an interesting question, I want to actually harken back. You came back to the example that Matt used about the first trip to Madagascar, and when Michael, the clinician in him, saw to it that this young child was treated for malaria in the moment. And I think I was just thinking about the ability of Pivot to both immediately launch clinical services and then also really invest in the data collection. And one of my other failed attempts that I didn't mention in my comments was I went to Rwanda with Michael and the team when PIH had been in Rwanda for less than a year. And the idea was that I was supposed to help the team develop a research agenda. But nobody was ready for a research agenda. The partnerships weren't in place. The environment was so sensitive. This was post-genocidal Rwanda, and there was so much urgent to do. And I totally understood that. I knew it was a missed opportunity because it was going to be a lot harder to demonstrate the impact. But those are very reasonable decisions, and that in Madagascar you found a way to do both at the same time, I think is kind of really remarkable. Who needs the data? We all need the data, Joya.
Yes. Right answer.
Luke needs the data. No,
I love data.
No, I know you don't have anything against data. I mean, I think it's a constant push and pull. It's a constant tension when you are doing work that is trying to right wrongs of the past and present to make decisions about how much do you invest in collecting data that is not going to have an immediate and direct impact on people's lives, and how much do you invest in the work that is going to have those immediate and direct impacts. And I think understanding that if you are in this for the long haul, then the data become even more important. If it actually, for the groups that are gonna be in for 2 years, 3 years, and then are gonna leave, monitoring and evaluation really doesn't matter that much because nobody plans to continue it anyhow. So I think the data really help us to inform what are the next steps. It's as much, as I said, about the how, or even more about the how than the if, once commitments have been made to stay. And I think this is where we get caught up a lot in the field of global health, is that so often the data is intended to be used as a yes or no, should we or shouldn't we? And I think the how is even more important.
Yeah, I mean, I'm reflecting on, the series of articles that you and Meche and others did in Peru early on, mapping out exactly what the problems were, from doing house-to-house surveys and seeing who had MDR-TB, from seeing how long people had been treated, how many. So it's like the decision makers will respond sometimes. So it isn't a yes or no, and that's, I think, really important. It's sort of the whole value chain from start to finish on what we can learn. Yeah, please.
This is something that became clear. I didn't know this in advance, but it became very clear in Madagascar that our relationship with the Ministry of Health was heavily influenced by being able to present data.
Yes,
and it's even before we had results. Yeah. It's like the relationship changed as we were able to show results, and it's amazing how much that becomes a differentiator from folks who are saying we have a plan, another project, to how the Ministry of Health thinks strategically about what they're doing. Yeah.
And you find these amazing people like Professor Samuelson that want to be part of the collection of data, the use of data. So I mean, that I agree that most ministries of health want the best for their people. And they're going to have to make really tough decisions on a day-to-day basis. And if we can provide together with them data is super helpful to people. It's rare that people say, oh, we don't really care if people do better on this or that. They'll say, well, now what do we do with that? So, yeah. In fact, I'll go back to Professor Samuelson, and maybe you can update us a bit on how Madagascar has been affected in the current moment, by cuts in aid, and how you think about using data and using these models in this space where you're having to make really difficult decisions.
That is a very, very difficult question, because the answer is a very, very difficult answer also. Yeah, we know that lately there was the USAID withdrawal, but we know also that it's not alone, because from the European countries, there is the war between Ukraine and Russia. And most of them would like to focus now on arming the military departments. And they reduce also their part in the basket fund. And that is very difficult. I would like to take, for example, an example on the fight against malaria. Because of this withdrawal, the PMI in Madagascar will not fund anymore the fight against malaria, for example. And this year, 2024, there is already a gap of 1.3 million for the meds, for the MRDT, malaria rapid diagnostic test, the ACT, then artemisinin combined therapy. All of that will have a gap of 1.3 million this year. And next year, because of this withdrawal, we will have a gap of 11 millions. Sure that the fight against malaria is done with rollback malaria, with Global Fund, but the distribution of the aid does not permit us to use the other funds to fill the gap that has been led by the Global Fund. So that is an example of the consequence of this problem. So what did we do this year? We did the prioritization of the limited resources that we have. And we did this exercise with the Global Fund, for example. The priority for them is to save lives and value for money. The different things that we had then is to make the activities in green, orange, or red. Red, you delete it, you don't do it anymore. Orange, then question marks, and green, we continue to do it. But there are some examples that I will take. For example, is the correction of the proportion of rapid diagnostic tests in the fight against malaria. We reduce it at 88%. And at the community level, we reduce it at 11.3% because of this shortage. Correction of the proportion for the treatment also, 80% at the health center level, and 14% at the level of the community. And he will talk about that perhaps after. So this kind of deprioritization is not good for the country. Another activity, for example, is the gender-based survey on malaria will be deleted. So this kind of thing, the research that we talked before, the data that we would like to collect are impaired by this kind of shortage. And the last thing that I would like to say then is that there is a need for the government to search for other funders and multiply actions to focus on available resources toward area where the funding is lacking.
Thank you so much. I'm so sorry to hear that, and I think malaria is an example of something that we see when there are cuts, immediate impact in terms of death, especially among children and pregnant women. So it's maybe Luke, you can share a little bit what impact you're seeing on the ground to our patients in Madagascar.
Sure. I think the disruption of the critical supply, such as malaria medicines, directly impact patients, such as the vulnerable patients like children under 5 and pregnant women. If we imagine like they come from far away, walking for hours, arriving at the health center in no objective to receive medication, and then they know that there is stock out, it's very disappointed for them. And the problem is like we conducted a study before around the work of CHWs, and we found that the reason why mother doesn't bring children at the health center is because of the stock out of medications. And in result of this, they don't trust anymore at CHWs. So for us as a medical NGO, we have to redefine our priority. And this has been like a challenging time for us. Like, okay, normally like Global Fund or other partner, or it should be free at the community. And now us as a small NGO, we have to prioritize this for the whole district, for example. It's very complicated for us. And for the clinician, even they have experience, they would like to provide quality of care.
Yes.
Without medication, it's quite problematic for them. So yeah, that's the situation. And I hope that we will find solution soon, because it's the impact will be complicated. Yeah.
Yeah, I mean, thank you. The impact is devastating. I think that I think someone mentioned last night, we need to double down on our efforts. We can't shy away from them. The world is really at a scary moment. I don't know, Matt, if you want to opine a bit on sort of what risks you see for not only Pivot, but for the health system as you know it in Madagascar.
What risks I see that have not been mentioned? I see Madagascar, when we started working in Madagascar, it was not eligible for foreign aid because of a coup in 2009. So the work that we started inspired, actually, if that's even the right word, by the need that was created in part by a lack of access to basic medicine and support. And a lot of progress has happened in Madagascar, or at least some progress has been happening in Madagascar since 2009 to 2014. But a lot of there have been persistent problems across the country, as like Lou just mentioned, including supply chain. Right? The stockouts weren't just invented by disruptions in USAID support. It's like a chronic problem. So the hope that what I see, honestly, it's very difficult for me to be pessimistic about the situation. And the reason is because I genuinely believe that, especially as we've experienced this work, with all of the problems that people describe in the context that was actually quite challenging, we've had huge epidemics, and we've had big measles, probably the biggest measles epidemic of the past 50 years, huge plague epidemic. We've had these cyclones come through every few years that are people say these things, but it's true. They are devastating. They displace people. They wipe out roads. They crush bridges. They destroy health centers, right? And during these times, as we're responding to emergencies and like providing food packages for people who are displaced or building tents or whatever, healthcare is responding, right? The community health workers are responding, healthcare systems respond, and in fact, anticipating these to some extent. And so to me, it seems not to be at risk of being naive. I see the problem or the opportunity as larger than the USAID. And when I also, I don't know if I'm going to say hopeful, but I believe, let's put it this way, I think there's a big misunderstanding of the power of small amounts of resources to have a large impact on people's lives. And I think some of that misunderstanding is in part because of the challenges of collecting data. That's certainly not the whole story, but it's a piece of the story. And when we can anchor the solutions on, yes, we have evidence, yes, the programs are happening, yes, we understand these challenging problems, yes, we can see results and produce the data, then I'm hopeful. Let's put it this way, the world isn't getting poorer. Yes, there's a war in Europe, but the resources are growing. The U.S. stock exchanges keep on rising, and the European stock exchanges keep rising. The problems aren't going away, and I genuinely believe that there are new ways of envisioning how resources get channeled to solve these problems. I don't know all of them, right? But I've seen it. I've seen it work at one scale. Let's put it that way.
That's great. Thank you. I mean, I think that I always feel optimistic too when I'm with these brilliant people and everybody's working toward the same. But knowing what Luke and what Dr. Samuelson are talking about on the ground, of course, we have to, as allies, think about how to respond. So I'm going to turn it to you, Carol, because you've been in this longer than I have, or close, or we're twins. So, what is our role in this space between academia and NGO supporting ministries of health? What is the role that we can play, and from your experience as allies in generating data and being advocates? What do you think we can do sitting here in Boston?
Yeah, at Harvard, no less. So I think there are a few opportunities. One is thinking about the long game. And I think there was a mention of education in this space and the link between these implementing organizations and academic institutions. So one is continuing to educate. We have some of our master students in global health delivery here in the audience, and I think it is really helpful to hear these conversations, to think collectively about potential solutions, to learn from other shocks, as Matt said. This is like the USAID, the collapse of USAID. Yes, it's unprecedented in that it's USAID, but it's not the first shock to the system that we've seen over time. So one is thinking about the long game. I think the other is continuing and doubling down on making common cause with those who are most vulnerable to these situations, precisely these families with young children who are going to really suffer from malaria, from pregnant women, and trying to understand what choices they would make and how we can help them to fulfill those choices in this setting. And the only way to do that is with organizations like Pivot, like Partners in Health, who are actually on the ground. And then doing whatever we can from our positions at Harvard to elevate those voices. There's been a lot of action around the cutting of foreign aid in the US, some of which has actually had an impact. So for example, while $5 billion is now on the verge of a pocket rescission of being cut from the federal budget, totally illegally, I will add, not giving Congress the proper authority to act on that, TB funding has mostly been retained this year. And I think that is at least in part related to the advocacy that has been very specific to TB. We've had this enormous blessing of the involvement of the YouTuber and author John Green in the movement to fight TB. His book came out earlier this year. He's been on Capitol Hill. He's in regular contact with his senator, the senior senator from Indiana, where he lives, and these actions do seem to be making a difference. Unfortunately, they're not having a broad enough impact. So right now, the Office of Management and Budget is holding up PEPFAR funding. Again, totally illegally holding it up. And so I think using our voices, using whatever platforms we have to reach out to our elected leaders in the US and parallel initiatives in other countries, they're important, they're worthwhile. Global Fund money is also, there was a tranche that was released earlier this year, but there is the potential for another, I think it's 1.2 billion to be released between now and September 30th by the US government. And so we do have a responsibility and a capacity to act and to try to communicate better about what the consequences are of not acting. Mm-hmm. I made a slightly offhanded remark earlier about part of our strategy around MDR-TB was to expose the risk that an airborne infectious disease posed. And that was really focusing in this instance on having a big burden of MDR-TB in the former Soviet Union and the risk that that posed to Europe, to really try to activate the Europeans to invest in this problem some. And so while it's not in my nature to talk about health as a security issue, that's not the way I think about it, that is really helpful for some audiences. And so I think being sophisticated about understanding what messages our audiences will respond to is another way we can act.
That's great. No, that's great. And I think, to the point about data, there are so many different kinds of data that you all have generated in your search, whether it's data, points like epidemiologic data, or whether it's data through qualitative means and storytelling, like Luke did so beautifully last night. I think these are all ways we can influence average people who actually support decency. They're average Americans who want us to do this. And so we have your back, Professor Samuelson. We're not going to forget about Madagascar and the struggles you're doing. And I want to leave some time for questions from the audience. So yes, you can.
It's more of a supplement to what was just said, but it's like, I feel like there are some people, maybe many people now, who are asking, geez, can you even have a career in global health? Is there even going to be an investment in these problems? And those are absolutely essential, legitimate experiences to have when, for example, your budgets are drying up and you have to figure things out. But let's also acknowledge that I don't think any of us went into global health for the money, right? I did. Luke was a nurse and was by far the most responsive person that I knew in Madagascar. Oh, here's a problem, here's a sick person, here's someone who's injured. I'm going to respond to this person, right? So it's when the problems rise, that expands the need to mobilize. And so mobilization is not defined by the USAID budget.
No.
It's a factor. It has to be strategic about it.
It didn't exist before.
Yeah. And so it's there's a lot of people repositioning and trying to get a sense of what are the institutions that are going to exist. And I don't know them into the future, but I do know that there's all the more reason to be committed to these issues.
Amen. So questions, comments, thoughts? Yes, D. Jordan. Are people online? Yeah, if people are online, even Loud D needs a microphone, and Loud Joya.
Yeah, so wonderful. I think everything that Pivot has done, I'm just blown away and so proud of all of you guys for making manifest what you set out to do. The question I have, I'm going to ask my mentor, Matt Bonds, and then I think Dr. Luke and Luke the same question. And also I would like to ask Robin as well. It's a question about, it's a serious question about equity, right? You guys have done amazing things in the districts you've been able to do them. How do you grapple with those you leave behind?
You and me be the first person to answer that question. I genuinely think Luke is like the appropriate person. I think, but I will. I'll do, because you're making me. I'll answer the question. The work is never done, right? Like the mortality rate dropping by 30% isn't dropping by 100%, right? Like the goals are to get it down to like 2.5% from from 15%, right? So. I guess inequity is one way of looking at it. I see it as a lot of like preventable and treatable illness that it continues to exist in Afanadine and obviously exists outside of Afanadine. And so the answer to it's not a cheap answer. It's to expand the programs, to be committed to improve the programs, expand the programs, and one of the real values of the data, and I actually don't want to overemphasize the data, I think that's a mistake, but in this particular case, it's important because health facilities are not representative samples of the population. They don't tell you who's not getting care. So you have to find ways to know who's not getting care. And the ways that we collect data, it's a combination of that population-based surveys. The GIS stuff is very important for the mapping. We do these kinds of nowcasts and forecasts to project what's happening in the population based on what's happening in the clinics, based on what we know of the disparity, which hopefully is diminishing over time. And the data is a little bit of a guide, as of a reminder of like where the inequalities are. And the truth is, the inequalities have been reducing significantly, including economic inequality and access to care. But obviously, there's still enormous burden. Sorry, maybe that was a long answer.
Yeah, Luke, would you like to, or Professor Samuelson, go ahead.
Yeah, I think that the question of equity is very important. I would like just to say to the team of Pivot, I'm inside as a board, but I would like to say that you've done a great job. So the main thing is to be the role model in Madagascar. How to replicate this kind of results in other regions, in other districts. And for that, you need to communicate. To communicate to the Ministry of Health, of course, you've done already it, but to students of medicine, to doctors, to all the professors in the different faculty of medicine in Madagascar. I'm sure that they need this kind of results to leverage also their activities in their region, in their provinces. And the last one is to advocate. You are doing the right thing right now, locally in Madagascar, but also internationally. So the advocacy that you are doing right now in front of those people, yesterday with the different funders, is the thing to do to make it possible to expand slowly but surely. Thank you.
Luke, I don't know if you want to comment on how you see, I mean, you gave a beautiful answer earlier about using the data to then expand the community program, but how do you see the idea of inequity from, people coming from other districts, or how is it playing out in the clinician, in the front lines of care?
Okay, that's a great question. I think when we intervene in Ifanadina district, there is a lot of person across the other district coming to Ifanadina for care. we support them, even if they are not included on the data, number, population, and the rest. But around the equity for us, when we deployed the community health activities integrity. Yes. Our objective is like to show to the ministry, like, okay, if we deploy this, if it works, we want to scale up for the whole country. And we, Pivot as an NGO, we were invited to be member of CHDP in Madagascar, in order to share, for example, our experience. And in this coalition, our vision is like to invite them on this replication program in the country, in the whole country. So our role as a pilot district in Fanadino region district in Madagascar is like sharing our experience to another partner, like the Global Fund or UNICEF or World Bank. Like there is an evidence around community health activities reinforced, for example. We should replicate those in other regions in order to give the opportunity and to set up this equity for the whole population. I think that's one of the objectives that we have to think about.
Thank you. I think Morgan had sorry, Dee wanted Robin to answer.
Just no, girl.
Dee's sitting there pointing to you.
I had probably 3 different answers going through my mind, of which Matt and Luke just gave. I think so. I'll as somebody who's not doing the day-to-day on the ground work or the science, I get to speak maybe from 30,000 feet, and I would just say that I think as an organization we aren't okay with leaving people behind. I mean, you can see that from the responses, and you can see in the specific actions. And we're there for the long term. And I'm not sure how we'll get to the whole country. I'm not sure how exactly we'll do it. But I think there's a very strong commitment that it's got to be doable. And if it was my family, I would want people to do this. If it was my family, I would want the best data so that I knew I was getting the best intervention, all these things. And I think that's a commitment that it runs deep through the organization. So that's my 30,000-foot answer, which has no practical actions on it. But
it shares your heart with the people in the room who, may not hear from the executive.
Okay.
Right?
A question from Morgan from Partners in Health.
Thanks so much for sharing all of your insights. I'm curious, a challenge that I imagine the government of Madagascar will also experience, like the governments that Partners in Health partners with, which is that the interventions that we have exceed their budgets. And I'll just ask this as directly as I can. What is the role of NGOs in strengthening the positions of governments in changing those budgets and other international policies that limit the space that they have to improve their healthcare systems? What do organizations like Pivot, what is the role, if any, in changing that landscape?
Okay, I think that's for you, Professor.
Yeah, thank you very much for your question. In fact, we cannot say that the NGO will change the landscape completely, but it depends on the amount of money that they will bring in the area or to improve the system. The policy of the government now is to open the door to any NGO who would like to help Madagascar to improve the situation in the health department. If they come, they are not able to do anything that they want, but there must be an MOU at the beginning between the Ministry of Health and the NGO, so that the activities that will be conducted by the NGO is in phase with the different aims of the Ministry of Health. And after that, they are able to do all the activities that they would like to do, and to bring all the amount of fund that they would like to reinforce, for example, at the health system. And that is the way the government is doing right now. In Africa, it is always difficult to think about how to improve our health system. It's very difficult. For example, if we take the example of Cameroon, for them, 345 millions of dollar is injected by the Global Fund in one cycle of the funding. For example, for the GC7, which is the grant cycle 7 now, in 3 years they will get 345. For Madagascar, we will get 125. But there was a cut, which is 1/6 of this amount lately. That was why we needed the prioritization. So this amount is very high. And it is difficult for our government, for example, to dedicate all of this amount in the improvement of the health system. So how it will shape the landscape, sure, it will bring a lot. That's why the policy is to open the access for every NGO that would like to help Madagascar.
Thank you. I think we can take time for one more question. Luke, one of our master students in global health delivery. Sorry, Arnold. I saw you too, but I saw Luke first.
I'm sorry, Arnold. Okay, my name is Lulu. I'm from West Papua province in Indonesia. And then I think when I was in university, I have like one of my friends from Madagascar, and she said that there's some area as well in Madagascar that do not have electricity and internet. So I work in the very rural area. We have same situations. So I agree that have real-time data will help the government to create such a really great program to help people. But at the same time, somehow there are some certain areas who cannot do that because of this, not really good infrastructure. So how can you get that real data from those kind of areas? I'm really wondering, because I've been experienced with tuberculosis and malaria in my own self. So I think that it's really bad situations and really sad for that people living in that situation. So can you give me like some strategy that you already have, or thank you.
That's a great question. So how do we think about using data in places where are the most difficult to generate the data? Do you want to take that, Matt? You're looking at me askance.
It's a really hard. So it's a great big problem. Good question. Madagascar faces the same problem now too, as so Professor Luke mentions the DHIS2, the national system for the health information system, and that is only as useful as the data, as the quality of the data that are entered into it. So it's not unique to Indonesia. Indonesia probably has a DHIS2 system as well. I don't know if that's true.
Maybe not Papua.
But so that's a way of nationally aggregating the registries from all the facilities. So there's like two questions. One is how to improve the quality of the data, right? And the other
I think the main question is how to get data from places that have no electricity or internet.
Oh,
I think
I'm sorry.
that's
I misunderstood
the question,
the
right,
question.
Lulu?
Well, okay.
Yeah.
What we do in those. Do you mean as how do you build that routinely into the health information system, or do you mean how to do your research? Because if we want to do research, what we do is we go in there and we take pictures of the paper registry. We photograph historically elsewhere paper registries. People take images of all of them, download those into a data set. So those are there's ways of, if it's about extracting, there are practical ways of extracting data that are in paper registries. If it's about the fact that paper registries don't exist, well, then you don't have data. That's a problem. So then you have to create the data system.
I'm going to pass this to Professor Samuelson. I think the question is, you're implementing DHIS2. We think that's a great tool. How do you think about it in areas that are the most remote, the least infrastructure? Will you do it, or will you use data from elsewhere and interpret that?
Yeah.
How do you think about that as someone who's thinking about the national scale?
Yeah. In fact, in the different health centers in Madagascar, there is always a paper on which we record all the different diseases physically.
Okay.
So if there is no internet, if there is no electricity, all of them should always send the results every week to the district level.
Okay.
Yeah. So at that region, they have the internet, they have the electricity. So they record at that level then the different data that are collected in remote areas where the electricity does not exist. But the other thing also is that more and more solar panels are now used, so it depends on the ability of the health center to get it or not, and that is one of the funding that has been scheduled, but now it's difficult to have them because of the cut.
Yeah. Go ahead, please, Luke.
Thank you. If we had our M&A team here, they will answer you correctly. But it's true. There is the physical system in parallel when we do data collection. But to improve the quality of data in Vanadina district, for example, we digitalized the system first, and they can record it without connection, without the network. And when they find connection network, they can send it after. So that's the system that we have made. But we have done an MOU with the Ministry of Telecommunication to expand more network around the district. Yeah. So we have this, they have this commitment with us to improve the data collection. Yeah.
That's great. Yeah, I think we need to wrap up, but I think that's an interesting question, Lulu, and it makes me think about something I've learned from people like Matt and Carol and others, that disaggregating the data is really an important part of our work, right? Because we have to look at who are not counted. It's often the most remote places. It's often the poorest people. And so as we collect data, we also have to look at what's the missing data and why is it missing, and how do we reach out to those communities. And I think some of the science really points us in that direction as we look at the most vulnerable communities. And I just want to thank Matt and Pivot for your leadership in this space. I want to thank Professor Samuelson and Nurse Luke for your amazing work that you're doing in a country that has really suffered a lot from the whims of aid. And we know you'll keep going forward. And I want to thank you all for being here. Thanks very much.
Thank you, Joya, and thank you to all of our panelists, and thank you for attending today. I am inspired every day to work with these people, and I hope you have been similarly inspired. I want to thank the HGHI team and Pivot for coordinating this event, and I invite you all to talk with our panelists as we finish today. Thank you.